Hi everyone, we're back for part 2 of chapter 11. So gastroenteritis is defined as inflammation of the stomach and intestine. It can be seen with side effects of anorexia, nausea, vomiting, and diarrhea. Acute forms may be caused by bacteria, viruses, parasites. You may have an injury to the bowel mucosa. It can also be caused by drugs and exposure to poisons. And in its chronic form, it can be caused by food allergies, food intolerance, stress, and lactose deficiency. So this next slide goes over some bacterial organisms. Be sure and read through those. And this slide goes over viral organisms and protozoas, and be sure and review those. Under pathophysiology of gastroenteritis, we know that most forms of enteric infection can cause diarrhea, whether it's bacterial, viral, or parasitic. And almost all forms of infection can result in diarrhea. We talked earlier about the definition of diarrhea is specific to the patient and what their normal bowel habits are. We know that diarrhea causes an increase in the frequency of the stool, having less form feces, and an increase in the water content in the fecal components. Diarrhea is not considered a medical emergency unless it's seen in children and in older adults, as they are less able to regulate their fluid intake. And it's also seen as a major infant mortality in developing nations. So the GI tract offers several defenses against infection. But when bacteria or viral pathogens can overcome these barriers, then they grow and cause varying degrees of gastroenteritis. We know that the acidity of the stomach is normally about a pH of 2, which does not allow for most organisms to grow. Peristalsis of the GI tract prevents colonization of pathogens. And with feces being primarily a water base and bacteria, these are the bacteria that help prevent the overgrowth of bad bacteria. And we also know that the GI tract produces immunoglobulins that protect against invading organisms. On clinical presentation for gastroenteritis, the patient may have nausea, vomiting, diarrhea, fever, abdominal pain or cramping, and then they also may have some associated symptoms of fatigue, malaise, anorexia. Tenesmus, which is the feeling of needing to empty your bowels, and then boroborgismus is the rumbling of the stomach. Exam may often be very normal in appearance. There may be some signs of dehydration, and you may see that with an elevated heart rate, dry mucous membranes, hypotension, dizziness, tinting of the skin in your older patient. A thorough history is very important and can help with what other diagnostic tests you may need, even though labs may not always be necessary. Those with severe diarrhea or systemic symptoms may require testing, and with diarrhea, examining the stool for consistency, blood, and fecal leukocytes is important. Under diagnostic test, if your stool sample shows some fecal leukocytes, then it might be suggestive of Shigella, Salmonella, C. diff, E. coli, etc. Stool cultures should be done if there's a fever over 101.3, severe diarrhea, or blood has been noted in the stool. Blood cultures may be needed to rule out typhoid or an enteric fever. If there's been travel to countries such as Russia, Nepal, mountains, or an exposure to infants in daycare, you might want to check the stool for OMP to assess for persistent diarrhea. Other tests may include a bowel biopsy, immunofluorescent antibody test, an ELSA study, and a flexible sigmoidoscopy. Management includes fluid replacement and those with sodium, such as Pedialyte or Gatorade. Hospitalization may be a necessity. Anti-motility drugs will help slow things down, but this is not to be used if the patient's running a fever, and antibiotics if there's concern. Patient education includes preventing the spread of the infection with hand washing, safe disposal of waste, and any child with diarrhea should not be back in school until this has been resolved. And then with traveling, safe food precautions and water intake. Let's next talk about peptic ulcer disease. And this is a generic term for ulcers in the stomach or the duodenum, and they're ulcers that penetrate the muscularis mucosa and is larger than 5 millimeters in diameter. So there's a lifetime risk of anywhere from 5 to 10% with peptic ulcer disease. We know that duodenal ulcers most often occur between the ages of 30 and 55 years old, and gastric ulcers are more seen with those between 55 and 70. And the causes of these ulcers include H. pylori, the ingestion of aspirin and other NSAIDs, and then having a stomach with acid hypersecretion. Some risk factors for ulcer development include what we talked about on the previous slide: smoking, aspirin and NSAIDs, and then H. pylori. On clinical presentation, you may notice that the patient complains of burning or a gnawing pain. Duodenal ulcers, their pain may be relieved by food or antacids. Gastric ulcers are often aggravated by food. They may have an episodic pattern. It may occur at nighttime, and physical exam is not useful to differentiate between peptic ulcer and other GI disorders. An upper GI is the gold standard of testing, and then for H. pylori testing, the ELISA test and the breath test are what you would do, and then you can also do a fasting gastrin level. Your differential diagnoses may include non-nuclear dyspepsia, cholecystitis, pancreatitis, IBS, GERD, gastric cancer, an MI or ischemia, and gastritis or gastroenteritis.